Psoriasis is what I'll discuss. And psoriasis, of course, is a rash, and it's most commonly described and appears as erythematous or red plaques that are covered with very characteristic silvery scales. And this is a very classic description of psoriasis. Now, I wanted to talk a little bit about the pathophysiology of what's actually happening. What you have in psoriasis is hyperproliferation of the cells of the epidermis, and those cells are called keratinocytes. And then in addition to this, you also have inflammation of the epidermis and the underlying dermis as well. And then what that does is eventually leads to scaling, and the reason the scaling is happening is because the epidermis is getting thicker. Epidermis thickens, and that leads to the scaling. So that's the essential pathophysiology. So why does this happen in an individual? Why would somebody get psoriasis? Well, there's definitely a genetic component. About 1/3 of patients will have somebody in their family that also has psoriasis. So there's definitely that component. But there's certain triggers that have been definitely identified that cause. One of them is injury to that area. Person gets injured and then later on develops this rash. The next one is sunburn, can be a trigger to developing psoriasis. A certain infection, and that is with streptococcus. For example, somebody gets streptococcus pharyngitis and then later develops psoriasis. That's a trigger. And then also certain medications can cause psoriasis as a side effect. Most commonly beta blockers, which are used for hypertension, ACE inhibitors, which are also used for hypertension, and lithium, which is used commonly for psychiatric conditions such as bipolar. Now let's talk a little bit about the symptomatology. Sometimes psoriasis can be asymptomatic, but if there are symptoms, they can include itchiness or pruritus. And then in terms of the physical exam, you're going to see these red plaques that are very characteristic, and they also are covered with this silvery, shiny scales. And I'd like to show you a couple of them, and here they are. So the first one is of course on the back of a woman's neck, and the second one is on the knee. And you can see that there's redness and erythema, but then there's also those silvery scales that are definitely present. And then there's one other important thing I wanted to mention. It's something called Auspitz sign. Now what that is that when a person has psoriasis, if they scratch the scale, then that can lead to bleeding. Now, one thing I wanted to mention that's really important in the identification of psoriasis is what part of the body it's actually affecting. Psoriasis affects certain very specific areas, and they're called extensor surfaces. So most commonly you're looking at the elbow or the knee. And then other cases of psoriasis can appear on the scalp or the back of the neck, like I had shown. Now, one very important thing to understand is that the location is a very big clue to what type of rash it is, because sometimes psoriasis can look like a fungal rash, right? Because it's erythematous, it looks like that. But fungal rashes are commonly seen in areas where there's increased moisture. So for example, the armpit, underarm, under the breast, and also in the groin. So if you have a red type of rash in those areas, think fungal. But if it's extensor surfaces, then definitely think psoriasis. And one thing I wanted to mention before I get to diagnosis and treatment is that as many as 30% of patients with psoriasis can develop something called psoriatic arthritis, where their joints are affected. So that can definitely show up in the clinical vignettes as well. Diagnosis is really just clinical. There's really no tests. Rarely is there ever a skin biopsy done. It's usually not necessary. And in terms of treatment, there's a lot of very specific and expensive psoriasis medications, and the big problem is that they're so costly that you always tend to go with the first line, which is just a topical, high potency corticosteroid ointment. And the most common one, or one of the most common ones, is betamethasone. And then also in the first line, I also want to throw in these vitamin D 3 analogs that are very helpful. And in particular, what I'm talking about, of course, is calcipotriene. Now, in terms of second line gets a little bit more serious, because second line, if first line has not worked, are systemic oral medications, and they include methotrexate and also a retinoid medication known as acitretin. But again, there are more side effects involved, so hopefully the first line will work. So now let's take a look at a few vignettes and see what this looks like. 38-year-old female presents with the itchy rash. She says has been present for the past several months. She has been using over-the-counter hydrocortisone cream with no improvement. On exam, she has large erythematous plaque on the back of her neck. The plaque is covered with silvery scales. Which of the following would be the best initial treatment for her rash? Well, initially always go for the topical corticosteroid ointment. And of those listed, that's choice A. B is a fungal antifungal cream. Diclofenac is actually an NSAID, non-steroidal anti-inflammatory drug. And mupirocin is also known as Bactroban, and it's an antibiotic ointment. And finally, 18-year-old woman comes to the clinic because of a 4-month history of silver rash on her elbows, knees, and around her belly button. She noticed the lesions during the winter, but was not particularly concerned because they were covered up by pants and long sleeves. Now it is summer, and she's too embarrassed to wear shorts or bathing suits. She has no significant past medical history, up to date on her immunizations, has not traveled. She takes no meds, no allergies, tries to avoid all sun exposure because she tends to burn and not tan. Physical exam shows erythematous plaques on her elbows, knees, and umbilicus. There's a silvery scale covering the majority of each lesion that bleed when you scrape it. The remainder of the physical exam is unremarkable. Most appropriate next step is advise her to avoid sun exposure. That doesn't really treat anything. Biopsy each lesion. Biopsy is not needed. It's not necessary. Inject each lesion with medium potency corticosteroid. This is one of the treatments, but it's not first line. It's not the initial treatment. Prescribe a medium potency corticosteroid ointment and topical calcipotriene. That is definitely a good option. And refer to dermatologist. Not necessary at this point. You could probably solve her problem with just a corticosteroid. I would probably go with a high potency, but medium potency is fine if you want to just start her off with that and then see how she responds. So choice D.